Well, thank you very much to EDS Support UK for suggesting that we have this joint webinar today. Some of you may have heard me speak before, and inevitably there will be some overlap, but I hope that you might be able to take something new away from this today as well. So during the session, I'm going to cover a little bit about what autonomic dysfunction is, medical associations associated with PoTS, how to diagnose it, how to manage it, and then if there's time at the end, I'll just talk a little bit about our charity and who we are and what we do. So autonomic dysfunction is when the autonomic nervous system malfunctions. The autonomic nervous system is the automatic nervous system in our body. It's the one that deals with all the functions that we don't have to think about. And I've tried to put it all together in this image here, and you can see that in this umbrella, it is an umbrella term. There are lots of other systems apart from the ones involved with PoTS that are controlled by the autonomic nervous system. So it controls, for example, the pupil, our breathing function, gut function, sweating, kidney system, and of course, blood vessel control, blood pressure control, and heart control. And very often people with autonomic dysfunction have problems in other aspects of the autonomic nervous system as well, not just in one bodily system. So when the heart and the blood vessel control, autonomic control, doesn't work properly, it can quite commonly cause something called orthostatic intolerance. And orthostatic intolerance is the development of symptoms in the upright position that are relieved by lying down. And there's a number of different syndromes come under this heading and cause orthostatic intolerance. For example, there's vasovagal syncope, where you have a tendency for the blood pressure to drop, and often the heart rate will drop or pause. Then you have PoTS, where you have a persistent increase in heart rate in standing associated with these symptoms of orthostatic intolerance. Orthostatic hypertension is a drop in blood pressure on standing. And then quite common is non-specific orthostatic intolerance. And that means that you develop these symptoms, these pre-fainting or pre-syncope symptoms, but when you're tested, you don't actually test positive for any of the other three. So what happens when a healthy person stands up? What happens in the body? Well, as soon as you stand up, a large volume of blood drops out of your chest cavity down into your abdominal cavity and into your arms and legs when they're dependent, when they're hanging down. And there's immediate narrowing of these blood vessels, and that sort of pushes the blood back up into the heart and then onto the brain. And in addition, in a normal healthy person, the heart rate increases a little bit by 10 to 20 beats per minute to help push the blood around in the upright position. However, in PoTS and also in vasovagal syncope and orthostatic hypertension, this mechanism doesn't work properly, and it results in blood collecting or pooling in the abdominal cavity and in the limbs. There's reduced return of blood to the heart, and there's reduced onward blood supply to the brain. And then to try and compensate, there's usually an excessive increase in the heart rate, and excess adrenaline and noradrenaline get produced as well to try and raise the blood pressure. So under the heading of orthostatic intolerance, you can see that there's a lot of overlap between PoTS and orthostatic hypertension and vasovagal syncope. And with both PoTS and orthostatic hypertension, the symptoms tend to be more chronic. In other words, they occur most days or every day over a long period of time. Whereas in general, people with vasovagal syncope tend to have episodes but be reasonably well in between times. And in all three of these conditions, as I mentioned before, there's inadequate or narrowing of the blood vessels. And this leads on to these symptoms of orthostatic intolerance that I mentioned before. So in PoTS, the three commonest symptoms are lightheadedness or dizziness, fatigue, and fast palpitations. Patients can also experience syncope, fainting, excess or reduced sweating, visual disturbances such as greying or of their vision, or sort of a visual flare, a glare. Headaches are common, shakiness, difficulty thinking, sometimes called brain fog, and hearing disturbances. And patients can experience other symptoms besides that. There's a huge list that potentially symptoms that patients can have. So these are the conditions that have been associated with PoTS, also known as comorbidities. And I say associated because it's quite important to be clear about what we mean by associated. And I'm going to talk about that a bit more on the next 2 or 3 slides. So hypermobile Ehlers-Danlos syndrome, or the hypermobility spectrum disorder, is by far the commonest associated condition. And then there's myalgic encephalitis, chronic fatigue syndrome, which, depending on the study you look at, 28% or around a quarter of patients can have PoTS. Autoimmune conditions are much more common in people with PoTS, and in particular Sjogren's syndrome, which causes dry eyes, dry mouth, and a lot of other problems as well, and that's quite commonly associated. Mast cell activation is associated with PoTS, also with hypermobile Ehlers-Danlos syndrome, when patients have often multiple allergies and flushing, and they can have severe allergies such as anaphylaxis. And then it's quite common for PoTS to be associated with a viral infection, and the commonest one used to be Epstein-Barr virus, EBV, or more commonly known as glandular fever. But of course, recently there's been an association with COVID-19, in that we're finding that quite a lot of patients with long COVID seem to have PoTS, and in fact low blood pressure is another common problem. And then there have also been individual case reports in conditions like Lyme disease, in multiple sclerosis, and in mitochondrial disease. And for those of you who are not so familiar with the hypermobile form of EDS, this is an image that we developed when I was working with EDS Support UK in the Royal College of GPs EDS toolkit. And hypermobile EDS and hypermobility spectrum disorder can cause fatigue, IBS-like symptoms, allergies, we've already mentioned that, chronic widespread pain. There's usually a family history, quite a strong one. Patients often end up with a diagnosis of medically unexplained symptoms. Migraine is common, a weak pelvic floor, anxiety-like symptoms, and poor sleep. Poor skin healing, stretchy skin and bruising, and patients have overly flexible joints that are often painful, and they dislocate or they sublux, which is like a partial dislocation. And then, of course, and depending again on which study you read, and there haven't been very big ones, unfortunately, on the whole, you will find that some of the patients have PoTS and some of the patients have orthostatic hypertension, low blood pressure on standing. So about 7 years ago, we did a survey of our members, and we surveyed over 1,000 people with PoTS. We're currently updating this at the moment. And our findings were published in the British Journal of Cardiology. And one of our findings was that about half of the people who completed the survey had hypermobility. Of course, we use different terminology for hypermobile EDS in these days. It's all changed since then. But the big question is it that PoTS is caused by hypermobile EDS? Or is there another separate condition that causes both PoTS and hypermobile EDS? Or is it simply that the two conditions are just really common and underdiagnosed, and they just by sheer chance happen to coexist in the same person? So these are three terms that are often used interchangeably, but they don't mean the same thing. And that is association, correlation, or causation. And it's quite a difficult concept, or at least it was quite difficult for me to get my head around it. But an association refers to any relationship between two variables or two medical conditions. A correlation refers to a linear relationship between two conditions. In other words, if one condition goes up, the other one goes up or goes down in proportion. And then causation means that the exposure produces an effect. So in other words, having one condition produces another condition. And here's an example of correlation in this graph here. And you can see that the lines are vaguely similar. And this is a graph of the number of people who drowned by falling into a swimming pool in the USA in a year. And you can see that it correlates with the number of films that Nicolas Cage appeared in. Now, there's a correlation there, but it doesn't actually mean that Nicolas Cage appearing in a film necessarily caused people to drown in swimming pools. So it's not a causative effect, it's a correlation. Now, this is really important, and I'm going to explain to you a dreadful paper that appeared in Brain recently about PoTS. And Brain's quite a well-respected medical journal. And what they did was they took a group of PoTS patients and a group of healthy controls, and they put them on a tilt table. And they noticed that the PoTS patients were developing a fast heart rate before they even went on the tilt table. And it was assumed by the researchers that this was due to anxiety. This didn't happen in the control group. But they then took this even further to say that this anxiety is the cause of PoTS. But of course, what they'd forgotten was that the patients who had PoTS had probably been on a tilt table before and had experienced how horrible it can be for some people to be on a tilt table. So it's hardly surprising that their heart rate went up a little bit, but it didn't necessarily mean that they had anxiety causing PoTS. They were just not looking forward to having their tilt test. So the researchers in this instance, they confused association or correlation with causation, and it's really important to get that right. So you can have an association or correlation in the presence, but also in the absence of a causal relationship. So when does an association become a cause? And these are some of what's called the Bradford-Hill criteria, that you have to meet these criteria for one condition to be said to cause another. And you need things like a strong association between the conditions. You need to get consistent findings. The exposure must precede the outcome. In other words, you must have one condition before the other one develops. A dose-response relationship, that's when one goes up, the other goes up. A potential biological mechanism, a sort of understanding of what's happening in the body, and some knowledge of the natural history of the condition. And then the ideally removal of the exposure should alter how often the outcome happens. If you remove one condition, the other one gets better. But obviously that doesn't apply when you're talking about genetic conditions like the hypermobile form of Ehlers-Danlos syndrome. So at the end of the day, the criteria have not been met for us to be able to say that hypermobile Ehlers-Danlos syndrome causes PoTS. So there's definitely an association there, but what we really need is more research on big populations in different countries over a period of time to be absolutely clear about what exactly the relationship is between the two conditions. However, it is very clear that they are associated, and even if we can't say one causes the other, it's still really important to recognise this association. And just to give you an example of that, when I used to work as a GP, I used to see patients who didn't have a very clear diagnosis in their notes. They usually had large volumes of medical records without having a proper diagnosis. And I would notice when I looked at their history that they might have been to see a cardiologist with either palpitations or maybe they were fainting. They'd often been under gastroenterology and they'd again come out without a clear diagnosis, maybe something like irritable bowel syndrome. And they'd often experienced joint pains and they'd been under rheumatology and again come out without a clear diagnosis. And I guess that might sound quite familiar to some of the people listening today. But when I saw that pattern, it would make me think of the hypermobile form of Ehlers-Danlos syndrome, and it would also make me think of PoTS. And so I used to at least, go down the road, right, ask the right questions and hopefully either diagnose or exclude it. So these patients with these associations of two conditions or more, they're often more complex patients and they often need to attend lots of different specialists, and really specialists need to coordinate care around these patients. And so it's so important to recognise that association to enable this sort of care. So how do you diagnose PoTS? Well, the key is in the history, and that's recognising these symptoms that are worse when you're upright and settle. Most of them settle when you're lying down, not all of them. When you examine the patient, you might see something called acrocyanosis. This is where you get this purpley colour in the arm, in the hand or the foot that's dependent, that's sort of hanging downward. And in both these pictures, the hand and the foot one was up and one was down, and they were only put together for the photograph. So that's called acrocyanosis, and that represents blood pooling. It's usually necessary to do some blood tests. There's no standard ones really, and they have to be guided by the patient's story. Patients should have an ECG because they've often got things like fast heart rates and chest pain and so on. And then sometimes other cardiology type tests are necessary, both in PoTS because of the way that PoTS presents, but we've been seeing a lot of PoTS related to long COVID, and these patients are not only experiencing a lot of cardiology sounding symptoms, but if you've got COVID, some people get proper cardiac problems, proper heart problems, and so they need to be checked out for them and have these conditions excluded. You can diagnose PoTS with a 10-minute stand test. You lie the patient down until they're settled and then stand them up against a wall, and using a battery-operated blood pressure machine, do the blood pressure and heart rate every 2 minutes until 10 minutes, and then lie the patient down again. Some patients do this at home, and they actually take the results to their GP or their specialist, but you've got to be careful when you do it because occasionally some patients do faint when you're doing a stand test. If the stand test doesn't produce a clear diagnosis, then sometimes a tilt table test is necessary, and that can only be done under specialist centres. And of course, when you're being assessed, you should be assessed for some of these associated conditions that we've been talking about. And this is what a tilt table printout looks like. So the patient lies down flat, and then when the special bed is tilted about 60 to 70 degrees with the head upwards, and that's happening here. You can see that in the control, the blood the blood pressure stays relatively stable and the heart rate only goes up a little bit by 10 to 20 beats a minute. But in this PoTS patient, when the tilt table's elevated, the blood pressure, it doesn't exactly drop, but it becomes very characteristically unstable. And then you can see in this patient that the heart rate rockets up, in this case, to about 180, 190 beats per minute, and it doesn't settle down until the patient is rested and back down, the bed's lowered again. And so there are a number of definitions around. One of the commonly used ones is this one from the Heart Rhythm Society in America. And to have a diagnosis of PoTS, you need to have frequent symptoms of PoTS on standing. There should be a persistent increase in heart rate of 30 beats per minute, more in children, more in teenagers. And this is important because when you initially stand up, everybody's blood pressure just drops for a few seconds and the heart rate goes up. But then it settles very, very quickly within 45 seconds, and that isn't PoTS. So the heart rate increase has to be persistent while the person's standing. And there should be no drop in blood pressure. However, some people, after having a PoTS response for a few minutes, can then go on and develop a vasovagal syncope episode. In other words, they can drop their blood pressure and faint. So PoTS is quite commonly misdiagnosed. In fact, half of our patients in the study I mentioned were given a psychiatric disorder to account for their physical symptoms. For example, they were told that they had anxiety or panic disorder, depression, or hypochondriasis, vasovagal syncope. Some patients were incorrectly given a diagnosis, that should be the other way around, of ME/CFS, although the two conditions can coexist. And in fact, in our study, there was a 7-year wait from symptom onset to diagnosis. And of course, this can be very harrowing for the patients. And there's been a term coined by one of the American charities to reflect the impact of this mislabeling and misdiagnosis on patients. And they've called it post-traumatic misdiagnosis disorder, which I think is an excellent term. So managing PoTS, first of all, you want to avoid triggers that will set off symptoms. So that's things like medication that lowers your blood pressure or tends to increase your heart rate. Prolonged standing obviously affects symptoms, and some patients, when they sit for a while, can be very symptomatic too. Both a hot environment and alcohol can dilate your blood vessels, and that tends to exacerbate symptoms. And also heavy meals, sort of rich in refined carbohydrates in white flour and sugar, and things like that, white bread, pasta, that sort of thing, can exacerbate symptoms. So we usually recommend that patients have a minimum of 2 litres, preferably 3 litres a day, and even more in a hot environment or if they're exercising. And children being smaller, we usually say that they should drink until their urine is a pale straw colour. Having a boost before rising in the morning out of bed is useful because patients are a bit dehydrated overnight, and their symptoms tend to be worse in the morning, so that can help to prevent that. And rapid water drinking is quite interesting. That's where you drink 2 glasses of tepid or cool water in quick succession. And that raises your blood pressure within a very few minutes, even before the fluid has got into your blood vessels. And it also reduces your heart rate. And it's thought to be due to an autonomic reflex, where stretching the stomach with the fluid helps to raise the blood pressure and reduce the heart rate and make people feel better. So that's a useful one in an emergency. There are some little tricks that you can use to try and help you with your fluid intake. It's useful to use one of the drinking bottles that's actually got the measurements on it. And in fact, when you're initially diagnosed and you're increasing your fluid intake, it can be useful. People often underestimate how much they're drinking, so it can be useful to get a better handle on what your fluid intake's like. And there are some apps out there that some people find useful to be able to monitor their fluid intake. Unless it's contraindicated, we usually recommend extra salt. So most people in the UK have about 6 grams a day, or should, 6 grams or less. And so having an extra 6 beyond that, in other words, a total of 12 grams a day or thereabouts, is useful. So that's an extra teaspoon, level teaspoon of salt, or for people who can't manage it due to gut problems, that's about 10 slow sodium tablets. But there are some conditions where it's contraindicated to have salt. You're not allowed to have salt, like high blood pressure, some forms of kidney disease, some forms of heart disease. And you've got to be super cautious in children who can be very sensitive to a high salt intake. A lot of patients, both with PoTS and with EDS, find that adapting their diets can be helpful in relieving their symptoms. Unfortunately, there hasn't been a lot of research done into this in large populations and with controls, in other words, with healthy people, or perhaps with the patient having one diet and then you monitor them when they're on a normal diet as well, and compare. You need that sort of research to see just how effective these things are. But ones that there's been a little bit more work on are things like the FODMAP diet. Patients with PoTS often find that avoiding gluten or avoiding refined carbohydrates is a useful tactic, and eating maybe 5 or 6 small meals a day is better than eating 3 larger meals a day. Again, we just need more research in this area to see what works best. And the other issue is that what works best for one person doesn't necessarily work really well for another person. Exercise is often recommended in PoTS, but of course, if you've got your PoTS due to hypermobile Ehlers-Danlos syndrome, then there's special considerations that you need because of particularly the joint problems that are associated with that. And then people with ME/CSF and people with post-COVID syndrome are often very exercise intolerant, and they can be unwell sometimes for hours or even days afterwards. And so particular caution needs to be exerted in these situations as well. It's helpful for patients to pace their activities throughout the day rather than trying to do everything at once. And if you are exercising, then it's usually a graduated regime that's recommended, starting sometimes at a very, very low level and not expecting to improve for 6 weeks or even 3 months. And usually exercise in a horizontal position is recommended, such as Pilates or swimming or recumbent exercise, biking and rowing, and then later on graduating onto upright exercise. We've recommended compression for a long time because a lot of the treatments for PoTS have been taken from the treatments for orthostatic hypertension, and that's been studied in orthostatic hypertension. It hadn't been studied in PoTS until recently, but there has been a very useful paper by Dr. Satish Raj's team in Canada, where they have looked at compression. And what they found, you can see from this graph here, that the purple line, the heart rate didn't go up as much when the patient had compression as it did in the person who didn't wear the compression. But what's really good to know is that the patients with the compression experienced less symptoms as well, because of course it's not really all about the heart rate. It's the most important thing is how the patients feel when you're giving them treatments and how it impacts on their quality of life. But what they also found was that they did different degrees of compression. So some people just had socks and then they compressed their thighs, and then they compressed their sort of pelvis and abdomen as well. And they found that the ones that had the full compression had a much better impact than the ones where they just had their calf muscles. In other words, they wore flight sock-like appliances, and that just didn't work as well. And it seems to be especially the abdominal compression that seems to be having the biggest impact on the heart rate and on the patient's symptoms. There are some postural maneuvers that you can do to help you prevent having symptoms, and also to help prevent fainting. And this involves activating muscles such as the buttocks and the thighs, and the calf muscles. So crossing them tightly, clenching buttocks. Also, rocking up and down on your toes can be helpful if you're stuck in a queue. Sitting down and elevating a leg to reduce the blood pooling, and squatting down in an emergency can be useful. You've got to watch with squatting though, because when the patient then stands up again, the blood pools or collects in the legs, and the patients can become even more fainty when they do that. So it's important to sort of stand up very carefully and slowly. There are a number of devices that can be helpful. Again, in an emergency, you know, for example, when you're transversing airports, there are different kinds of portable stick stools. This is one that a lot of patients seem to find really helpful because it folds down and goes into this tiny little bag, although some of them are just a bit too tall for the patients to properly sit. You don't want your stick stool to be so tall that you're effectively standing, because that doesn't really help. You need to be kind of sat down a little bit with your knees almost at right angles, preferably. This is a tiny little pocket stool, and this one is one that folds down into the size of a Coke tin. Temperature regulation can be very important for some patients. It's useful to dress in layers so that you can discreetly sort of layer them off and on as you need to. Some people find ice vests are useful, and there are these sort of sporting towels that when you wet them, they feel still quite dry, but when the fluid evaporates, it cools you down. So some people, for example, wear them around their shoulders in the hot weather and find that that helps their symptoms. We get asked a lot of questions at the charity about the impact of hormones on PoTS, and certainly there have been some good studies that have shown that women often have exacerbations around the time of their periods. But again, there haven't been good studies that show the best sort of treatment options that are available. I can tell you my personal experience when I was working as a GP and what seemed to work for my patients. So if patients were sort of on a monthly basis finding that with the periods that their symptoms were much worse, then by stopping their periods, that could actually help with their symptoms. So using the contraceptive pill, the combined pill, but instead of having the 7-day gap, I used to run it together continuously, either on a 3-monthly cycle, or some nowadays it's off license, but you can actually take the contraceptive pill for a year without a break, but has to be discussed with the healthcare professionals, of course. But a lot of people with EDS and with PoTS have migraines, and certain types of migraines you can't use the combined pill. The mini pill can be used in migraine, and that's taken continuously. It doesn't have estrogen, and that can be helpful. And sometimes I used to find that the subdermal implant called Nexplanon, a little implant under the skin, and the Mirena coil were also quite helpful in these situations. They all stop periods, or are supposed to. And then again, I get asked a lot of questions about the menopause. Again, there hasn't been much in the way of studies as to whether HRT helps. What I used to do with my patients was we would have a chat about it, look at the risks and all the rest of it, and the benefits, and then maybe just give them a trial. And some people I found were much better on HRT, and some people I found were actually worse on it, so we stopped it again. Traveling can be especially problematic for people with PoTS and EDS. If you're traveling on the Underground in London, there are some apps available that can guide you through step-free access to some of the underground stations. And on the underground, they have some badges and cards that say, please offer me a seat, that people can wear. And if they get noticed, some people will offer you a seat. And in fact, some of the regional transport systems, this is the West Midlands one, also have these badges, and usually you don't have to provide medical evidence. You can just write to them and ask for one of these badges if you think they would be helpful. Airports can be especially challenging, and I guess some of you will be familiar with the special assistance, which is more designed towards people with specific disabilities, such as people who use wheelchairs or have hearing or visual challenges. But there has been a push in recent years for people in airports to be trained to recognise invisible illness, which is a huge step forward. And there's this lanyard which can be obtained either from the special assistance or from the airline. And the Sunflower lanyard just highlights to airline staff and airport staff that you have an invisible disability and that you might need a little bit of extra help, for example, queuing through, queuing when you're going through security and so on. Especially for people who faint, sometimes having some kind of emergency notification as to what to do or how to get help can be useful, and people wear bracelets. You can add your emergency contacts to your mobile phone. And then there's ICE cards in case of emergency. And PoTS UK developed some of these in recent years. And also Hannah Ensor of Stickman Communications has got some neat little cards on her website as well. If people are what we call decompensated and they suddenly become much worse, for example, if they're dehydrated with gastroenteritis or they've got hyperemesis, that's vomiting during pregnancy, then sometimes it's necessary to use an intravenous infusion to rapidly give extra fluids. There has been quite a vogue for these in the last 2 or 3 years, where patients have been asking us how they can get access to IV infusions to help their symptoms. But there is quite a lot of caution because there haven't been good studies. There have been 1 or 2 studies, but they haven't been controlled, and they've been very small numbers, and there's been little in the way of long-term follow-up. So we don't really know just how effective the IV fluids are in comparison to oral fluids. And of course, some people can't take oral fluids. They have these challenges, and that has to be taken into consideration. And there are some risks with having regular IV fluids when you've got a sort of cannula permanently in to allow access. So really, we desperately need some more research in this area so that we can be able to appropriately advise patients. Sometimes cognitive behavioural therapy can be helpful. So some patients were very, very healthy, and suddenly they find they've got this very debilitating condition. And it can sometimes be helpful to have psychological therapies to help you adapt and sort of cope with the new situation that you find yourself in. Not everybody needs that, but some people find it helpful. And also PoTS causes very scary symptoms: chest pain, breathlessness, fainting, and so on. And again, some people find it helpful to have psychological therapies to help them to be able to cope with these symptoms. But of course, when we're talking about CBT, it's not because we're saying that the symptoms are all in your head. These are just psychological therapies that would be offered to anybody who's got a chronic illness and in situations when it would be recommended. So usually, if after 3 to 6 months there hasn't been sufficient improvement, medication can be used. Some people who are very, very unwell will receive medication at an earlier point than this. So the first thing to do when thinking about medication is to remove drugs that trigger symptoms that I mentioned previously. And then adding in new medications. The medications, they aim to improve blood volume, In other words, take on more salt and water. They narrow blood vessels, and in PoTS they reduce the tachycardia as well. And so there on the right hand side there's some examples. There's a lot of overlap in the treatment with orthostatic hypertension, but we tend to find that the drugs that the patients tend to find initially most helpful are ivabradine and midodrine, either one or the other, or sometimes patients are given them together. And certainly most studies that have been done to date have been done on beta blockers. Not everyone can have them, for example, if you're asthmatic. And we tend to find that the patients tell us, and also the studies tell us, that if you use just a little dose of beta blocker, you can often get some benefit. But when you use a larger dose of beta blocker, the patients start to get worse again. So this is really a case when little is more. And I can answer some questions on the medications if you've got any specific inquiries at the end. Then on the PoTS UK website, especially when people don't respond to the lifestyle changes, or they need anything other than the most simple of medications, then referral to a specialist is necessary. Some people need referral earlier because they're finding that their healthcare professionals don't know enough about it to even offer the basic sort of therapies. Unfortunately, there aren't enough specialists in the UK, but the ones that have put themselves forward to be listed, you'll find them on our website. So just briefly, a little bit about the charity. The top row are all the trustees of PoTS UK, and on the bottom row here we have Jo, who was our first employee part-time. Jo's on maternity leave at the moment, and Denise is doing a sterling job of supporting the trustees and the patients and the volunteers while Jo's on maternity leave, and hopefully for longer. We have a lot of volunteers now that are helping us, and we couldn't really manage without them. This is just a few of the team. And so Awareness Day started in October 2019, and for the first Awareness Day, the Blackpool Tower lit up purple. And in fact, today and yesterday, we've had dozens of places all lighting up purple to raise awareness of PoTS. And during Awareness Month, the whole of October is Dysautonomia Awareness Month, and there have been quite a few sort of fundraising activities going on as well, and these all help to raise awareness too. We started off as a charity, as a Facebook page in 2010, and then soon after developed a very rudimentary website, and the website has recently been considerably upgraded. And on the website, there's lots of information about how to manage PoTS, and as I mentioned before, there's also a list of specialists. Just again in recent years, and through a lot of support from our volunteers, and recently Denise as well has made a big difference to our Facebook page. So we have started engaging in these other platforms as well. And we have a YouTube channel with lots of webinars for patients and healthcare professionals. We run patient events from time to time in person, and we also offer educational events for healthcare professionals. And there's lots and lots of other activities that we don't do, and I think are probably very similar to those of EDS Support UK. And this is perhaps our youngest volunteer. And with that image, I'd like to say thank you very much for listening.
Brilliant, thank you, Leslie. That was absolutely fantastic. Loads of amazing information on there. And yeah, so much on there. It's really fantastic, thank you. I've got a big long list of questions, so we'll try and get through as many as possible. Some of them I've kind of grouped together as well, because they're of a similar ilk. So I will start working through those. One question, well, we had a couple of questions that came under this, which was a lot to do with diagnosis. So either private diagnosis being dismissed, or GPs not putting through referrals for cardiology to diagnose, and kind of what would you suggest about combating this and the conversations to have to get around that?
Yeah, that's a difficult one, and you know, we really need the whole NHS environment to change, and it should. You know, people with these conditions are not getting the same access to healthcare as some people with other conditions. Sort of advice that I usually give when I'm answering the patient inquiries are, first of all, you're not entitled to a second opinion on the NHS, but very few people would not allow you a second opinion. And therefore, you know, sometimes just seeing another doctor in the practice can be useful, or perhaps asking to see a different member of the team if you're under a specialist team, and sometimes you can get a different response from that person. It doesn't always work. Also taking medical information into the healthcare professional that you're having difficulty, you know, accessing your care through can be useful, but I would recommend that you keep it brief and to the point and try and get it to cover the main issues, because most people, certainly in primary care as GPs, have 10-minute appointments and they can't cover a lot of ground in that time. So on the PoTS UK website, we developed a one-page summary of what PoTS is, how you should manage it, how you should test for it. And I usually recommend that people just take in the one page and just try to educate your healthcare professional with that. I mean, if that's not working, sometimes writing, it depends on your situation, but sometimes escalating it to maybe the practice manager, seeking help from PALS, the patient liaison service at the hospital. Sometimes they can be helpful in giving you advice and helping you to negotiate the system. And sadly, some people have found that they've had to speak to their MPs before they've been able to get the help that they needed, and occasionally that works too.
Perfect, thank you. Quite a few people saying that they're experiencing symptoms, say when they're sat down or they've just eaten, and then how long it's taking them to stabilize, say after standing up, and those symptoms and things. What to do to address that, to address those symptoms whilst you're sitting down and having them, as well as how long. It's going to be a difficult one because it's going to differ person to person, but
it will.
Would it be the general kind of looking at those management tips and then fiddling around with them to see what works?
Yeah, I mean, it would be maximising as much as you can of all the things that I've just spoken about. But there are a couple of things that you can do in the specific instances that you mentioned there. So if people find that after they've been sitting down for a while, they become very symptomatic, then sometimes sitting with your legs elevated or even slightly reclined can be quite helpful in reducing the symptoms. And then again, even when you're sitting, activating muscles. So for example, just fidgeting or sitting with your legs, your arms quite tightly folded, or just pumping a fist can all help to raise your blood pressure and reduce your heart rate. So these are little things that can help as well. Regarding eating, so how long it lasts for, really, I mean, that is hugely, when you're sitting, that's hugely dependent on the individual. Some people, when they put their feet up, start to get symptom relief straight away, for example, and others eventually just have to lie down if they're having severe symptoms. Regarding eating, there are a number of different things that you can do. In fact, we have a couple of we've got a couple of webinars by Professor Aziz on our YouTube channel. So you could have a look at these. They're more targeted to healthcare professionals, but there's quite a lot of tips on there about things that you can do to help manage these symptoms when you're eating. But he says that eating very slowly can be helpful. Some people have to eat when they're more supine with their legs out. and just altering the type of food. So avoiding these refined carbohydrates can be very useful. Eating what they call low GI foods relieves some people's symptoms. I mean, some people get symptoms quite quickly when they're eating, but for some people, the impact is actually delayed until maybe an hour and a half later, when the food gets into their bloodstream. And so initially it can actually be quite difficult to make the connection between eating and having the symptoms. But once you recognize it and you can start to work on it, then it can improve things for some people.
Brilliant, thank you. Quite a few questions about children in terms of age that diagnosis is possible, management for kids as well. You know, they're struggling in school with getting their symptoms under control, and what's kind of advice that someone hears as well. Their daughter's taking sodium tablets and fludrocortisone, but it's not helping, and there's someone else having difficulty getting diagnosis and acknowledgement of what's going on as well.
Yeah, I mean, I think nobody's served particular, or very few people are served well in the UK when they have PoTS, but I think that children must be the least well served. There's a lot of issues, first of all, around diagnosis. People don't like to do studies in children, and so the problem is that you then don't get things like diagnostic criteria. The diagnostic criteria don't start until people are 13. So you end up applying the diagnostic criteria for older people to younger people, and that isn't always the best thing to do, but sometimes there just isn't anything else there for people to work with. So that's a big problem. And also in terms of managing children, people don't want to do research into using medications in children. And so, you know, there's so much less medication available that's licensed for anything in children, never mind PoTS, because the research and the licensing hasn't actually been done. Regarding getting a diagnosis, that's really hard. You can try the one-page leaflet from the website, take that to your GP, but I'm sure that even if it's recognised, GPs would have a much lower threshold for wanting to refer patients on to specialists, but there's almost no specialists around, and some of the ones that we did have are actually not being allowed by their hospital management to see PoTS patients. They say things like, well, we never had a PoTS service, it wasn't commissioned, it wasn't bought as a PoTS service, which is ridiculous. So, you know, I've lost count of the number of letters and things that we've been writing to hospital management, so on, to try and get them to maintain services that were existing and were being stopped. So we do get the odd person that pops up, and sometimes people pop up but they don't want to be listed on our website. There's nothing we can do about that, really. But there just really aren't enough, and we're always trying to lobby MPs and hospitals and various other people to improve it, but it doesn't help these people for now. In terms of education, we do have a little section on the website talking about how to approach PoTS in school. Some people might find that helpful. Obviously, talking to special needs teachers, sometimes you have to get the healthcare professionals involved as well, but having had a daughter in school who had PoTS, I know how challenging it can be to get them the sort of help that they need.
That's brilliant, thank you. A few questions about kind of gastro symptoms and PoTS, and whether go down the gastro route or go down the cardiology route in terms of specialists, and kind of who to see and what's the best route to take.
So I think it really depends on partly on what the patient's priorities are in terms of their symptoms, if you're going to have to address one before the other. It's a bit difficult with the gut problems in PoTS. It's not always clear whether it's the PoTS that's causing the gut problems? If people get diarrhea, is it an exacerbation of the PoTS that's causing it? Or is it something like the associated conditions? Because a lot of people, for example, with EDS, get gut problems. And is it the EDS that's causing the gut problems, or is it specifically the PoTS? Because you would take a slightly different approach depending on which one it was. If it was the PoTS, then you would be wanting to maximize your PoTS therapy. And that might be done through your cardiologist or your PoTS specialist. Whereas if it's the EDS, then it might be that you're going to go down more the route of the gastroenterologist, but it will depend on the individual. I mean, I have to say, with the gut problems, when I was working as a GP in the Midlands, there were no gastroenterologists who had any interest in EDS or PoTS. And so I had no support out there in terms of help me manage my patients. So I just had to do it myself as a GP. And I know a lot of GPs won't do that because they haven't got the level of interest. And I used to find that a lot of the treatments were symptomatic, really. So, if people had nausea, then you would just treat it with an anti-nausea medication. If they had excess motility, in other words, they had diarrhea, then you would treat it with sort of anti-diarrheal type medication. If they were very constipated, then you would treat it with medication that treats constipation in any other condition. If you had overgrowth of the bacteria, then you would use the sort of probiotics and things that you would use for anyone else with overgrowth. So I don't know that the actual treatments for the gut problems varies hugely. I'm not talking about everybody, but in the majority, you do tend to treat them just the way you would treat anybody else with these sorts of gut problems.
Yeah, no, that's brilliant. Thank you. I think we've got time for a couple more, if that's okay, Leslie.
Mm-hmm.
So I'm scanning through what people have said. Someone here who is unable to drink over 1.5 litres of fluid due to a suprapubic catheter, what route would you advise for them in terms of getting their symptoms under control?
Well, obviously, I can't speak about an individual because I don't know their individual issues. And in fact, some people with suprapubic catheters are advised to drink plenty fluids. So, it varies depending on the individual's circumstances. But in people who can't drink 1.5 litres at once, or sort of say get that early boost in the day because it causes them problems, then it often comes down to having just very small amounts and just keep at it and just have that water bottle by you, so that you're not having a large volume at once, but you're just trying to spread it as much as you can throughout the day. It won't solve it for everyone, but same with people with gut problems. A lot of people have gastroparesis and they just could not possibly drink a litre of water in one go and do that rapid water drinking. And they have to just make sure that they just get small amounts, but all the time. I mean, rarely people do come on to needing other types of fluids when they're very severely ill with it. And there is a minority who do need to have these special feeds and IV fluids, but there are the risks. So you always have to look at other alternatives before you kind of go down that road.
Brilliant, thank you. In terms of, there's a few I know covered hormones within the presentation, so this may have already been covered. Just some conversations, one about the depot injection, and two about any relationship between endometriosis and PoTS as well.
So in terms of the depot injection, so people who have exacerbations around their period, and you've made a decision with the patient that they want to try and put their period away, and they might need contraception as well, then you can use the depot. in younger people, bear in mind that not exclusively, but a lot of people start to develop this in younger years. And if you give depot to very young people, it can affect their bone mass and make them osteoporotic. And of course, people with EDS are more prone to osteoporosis, I understand as well. So you want to be really quite cautious there. Also, when the depot doesn't work and it causes side effects, you're stuck with it because it's in there for weeks and weeks. Yeah. So with other things, when you give a medication and it doesn't suit a patient, you can stop it. Whereas when you've got the depot, you can't just stop it. And for that reason, that was never my first, well, for all these reasons, it was never my first choice in managing these situations. So it's not that I didn't use it, but it would be kind of the last one down the line in terms of choice. But it's, again, it's a very individual thing. You have to counsel your patient, chat to your patient, see what they want, what their preferences are, and then put all these things together till you come to a decision with the patient.
Perfect, thank you. And then if we just have one last question. I'm just going to see if I can find it on here.
Oh, endometriosis, sorry, I didn't answer that one. I'm not aware of a link particularly. It's not that there isn't one, but it's not one that I've encountered.
Okay, brilliant, thank you. So someone here, I have HEDS and ME plus all the symptoms, diagnosed a few years ago before I was 60. I am being told by experts that I am the wrong sex and too old to have PoTS. Surely PoTS is a condition, you know, it can't be restricted to just young women. That seems madness. So kind of how to get around that and to challenge that as this individual, who I assume is male and older, and to try and get the doctors to listen.
Mm-hmm. Yeah, I mean, that is quite a common one. And I mean, there is a scenario that gets confused in an older age group with PoTS. So some people who are in their 50s and 60s, they drop their blood pressure when they stand up and they develop a reactive tachycardia, but the blood pressure drops and the heart rate goes up sort of quite early on and at the same time. And that isn't actually PoTS, but it gets mislabeled as PoTS quite a lot. Having said that, mostly the treatment is the same as it would be for PoTS anyway. It's all about the fluids and the postural things and compression and so on. So we do see that happening sometimes, but there are some people out there who do seem to get it. They just are in a minority. I've had a few medicine for the elderly consultants talk to me who look for PoTS in their older patients and don't find it, but they know about it and they're quite surprised, and they don't, and we don't understand where it goes in this age group. But you know, you can never say never, and when you have these trends and things occur in young people, then when older people get them, then the clinicians miss the diagnosis, and that's a very difficult one. And I think it again comes back to, you know, if you've had a stand test or a tilt test and it doesn't show that drop in blood pressure that's more common in people in that age group, and it is a purely PoTS response, then I think it would be going back to all these things that I spoke about earlier, about maybe asking if you could see somebody different, maybe taking a leaflet from the charity website to chat to them about it. Just that, you know, the usual sort of things that you have to do when you're not in agreement with the diagnosis that you're given by a healthcare professional.
That's brilliant, thank you. I know there's been questions that we haven't been able to get around to, but I'm also conscious of time as well, and especially the kind of medication specific questions are very difficult to answer just because you need so much more information to go with that. Leslie, do you have an email address that's the best email address to use for people to say if they wanted to get in touch?
Yes, so we've got a new system actually working at the moment. We started it just over a month ago, and we've got a new team, and they're healthcare professionals who are now answering questions. So it's not just me that's doing it, and that's at support@potsuk.org. And they've been doing a fantastic job over the last few weeks. So that's meant to be the one for inquiries. However, as I'm sure with the EDS Support UK, we can't really answer individual medical inquiries. That still has to go to your healthcare professional. We can give you some pointers about questions that you can ask your doctor, but we can't kind of give you a medical opinion. So I would say, you know, unless it's something that's specific to the talk I've given today, then I answer everything on info@PoTS UK or leslie@potsuk.org. And if it's a general sort of patient-related inquiry, then support@potsuk.org is the address that you want.
Perfect, thank you. And it's been recorded, so for anyone, I know there were a few people that said they came in a bit later and things like that, you will be able to watch it back. It will be edited first. Guy, our IT wizard, does stuff to it that then means we can share it on different platforms. Leslie obviously will send it to you as well. You can share it on everything there as well. It's handy. We do tend to remove the Q&A bit at the end because it tends to have more personal details. So for anyone who worries where that's gone, that's why we remove it. But any further questions, do feel free to get in touch with PoTS UK or EDS UK, either or. Be happy to help. Thank you again, Leslie. It's been absolutely fantastic. Really, really helpful. I can see we've had really fantastic feedback as well from everyone that's attended. And I'll send that through as well. It's always nice to see the happy faces saying how well it's gone. And yeah, great awareness for PoTS as well. So thank you very much for everyone for attending. And do please give us a shout if there is anything else you'd like to ask. And thank you, Leslie. I'll let you go have a rest now.
Well, thank you for hosting as well.
No problem at all. And take care, everyone, and thank you for coming. Bye.